Great. All right. Thank you so much for joining us today for MVC's Health and Action Workgroup Patient Journey Mapping. My name is Emily, and I'm a Site Engagement Coordinator here with MVC, and it is my pleasure to be facilitating this work group for you today. Hopefully everybody can see my screen. Before we introduce our presenter for today, I wanted to review just a couple of housekeeping items. First, this work group session is being recorded, and the slides and recording will be shared with all attendees following the work group in that follow-up email. Second, a reminder to please double check that your mic is muted throughout the presentation. We'll ask you to unmute during the breakout sessions today, but during Jana's presentation, for the quality of the recording, we just ask that you remain muted. And then finally, we will be monitoring the chat throughout the presentation if you have any questions. But we are going to have a couple of breakout opportunities as well as a end of the presentation Q&A. So we'll most likely be able to answer your questions at that time. Okay. For those attending this work group for P4P credit, we look forward to your active participation throughout the work group. We have a couple of polls as well as those breakouts, as I mentioned. We will also be sharing a post work group survey at the end of today's work group. That link's going to be provided in the chat as well as in the follow-up email. And for hospitals participating in P4P who would like to receive credit, that survey is mandatory. Please remember that you will indicate the hospital that you're attending on behalf of in that survey so that you appropriately receive credit for your attendance. All right, I'm seeing a couple other people pop in, so I'm just going to very quickly give our agenda for the day. We are already gone through our housekeeping. Next up is a presentation on patient journey mapping by Jana Stewart. Then we're going to have 2 breakout sessions and then followed up by a discussion and Q&A. All right, today's presenter is Jana Stewart. She is our Associate Program Manager here at MVC, and I'm very excited to have her presenting. This is a continuation of a presentation that Jana provided, or a work group workshop, actually, that she did at our fall collaborative-wide meeting this past October. So we're really excited to have her back. All right. With that, Jana, I'm going to let you take over the screen sharing. Hopefully this is nice and smooth.
Does that look all right to everybody? I can't hear you, Emily.
Oh, yes. Looks great.
Perfect. All right. All right. Good afternoon, everyone. Thanks for joining today's session. I am excited to dive into a topic that I really believe can transform sort of how we think about patient care and outcomes from kind of a non-clinical perspective. My background is in sort of education and communications and have done some work with supporting teams with sort of human-centered design in the past. And so I'm excited to kind of use those skills in this session here today. So as Emily mentioned, we did do a breakout session in the fall that was focused on this as a breakout session. So part of today's presentation will be a little bit of a review of the core concepts that were presented then, just to make sure that we're all on the same page. But since then, we've sort of taken what we learned from that session, from all those small groups, to identify some opportunities for improvement and come up with some possible strategies to deal with those. And so part of today will be about sharing those with you, leveraging your insights, your expertise, to get us a little bit closer to generating some kind of ready-made resources that you all can use within your own teams to improve follow-up and outcomes for heart failure patients. Okay. So I want to kick off a little bit just for myself to know who's in the room. So we're actually going to start with a poll so I can get a sense of who has experience doing patient journey mapping, whether you were part of the session in the fall, whether you work with this patient population. So I'll ask Emily to start that poll. Um, while you're doing that, I also want to mention as you're working in your breakout teams or asking questions within this space, it might come up that you have specific patient examples or references that support the conversation. I do just ask that you try to be considerate about sort of the identifiable information you use in those because of the fact that we're recording this and it will appear online. Just making sure that we're being careful about the examples that we share. Okay. Seeing that we've got most people have completed the poll. Let's go ahead and end that and share the results. Get a sense of who is here. It looks to me like the majority of folks did not attend the fall meeting, so some of this may be new information, and that most people have not utilized patient journey mapping as an approach before. And kind of a mix in terms of whether heart failure patients are a project of focus for you personally or your team. Okay. Great. That's helpful. Okay. So these are my goals for today. Like I said, I'm going to review some of the core concepts and considerations that are important to keep in mind whenever you do a patient journey map. Then we're going to discuss some of the patient journey map examples that came out of the fall breakout sessions and some other solutions that we've come up with. And then at the end, we'll kind of come up with a plan for how to leverage today's breakout discussions and ideas to carry those forward to generate some materials. So generally speaking, I know that in healthcare, we're all sort of working to provide the best care possible. Sometimes that can go beyond clinical expertise. So about understanding and anticipating sort of the touch points that are needed, patient needs along the way, is really exactly what patient journey mapping is meant to do. It's a way of sort of seeing the experience from the patient's perspective. It's a really nice use case for patient experience data in conjunction with other information and data. And it kind of helps you to do root cause analyses, think about opportunities for interventions or other strategies to re-engage patients. And so we will explore that together. Part of this is not just kind of a standalone strategy, but more of a mindset shift around kind of where the focus goes and kind of centering it on that patient satisfaction piece. So generally speaking, it's really focused on literally documenting from A to B to C, what are all the different steps that a patient takes, and how does that taking that step or doing that action impact that patient emotionally, physically, because those types of things can influence how they then approach the next step in their care, whether they take the next step in their care. So there's a few different ways that you can go about doing this. There's actually more than the two that I've mentioned here on this slide. There's maybe 4 or 5 different types of journey maps, but the two that we're going to be focusing on today and that we focused on in the fall were our current state journey map, which is really focused on that patient step piece. So what they're doing, what they're thinking, what they're feeling as they interact with the healthcare system. And some of that is going to have to do with things that happen outside of your 4 walls. So it might be, the interaction that they had with the pharmacist. It might be the process it takes to go about getting medication. It could be connections that they have with a community support group for that patient population. It's all those pieces that impact how the patient cares for their well-being. The service blueprint is a little bit more organizationally pointed. So it's really documenting in sort of a flow chart or a diagram the workflow that the health system or the hospital staff are taking. So it's likely going to be documenting different systems of communication, actual steps that those staff are taking and documenting. It might also have connections to partners where there's existing partnerships and collaboration. You can kind of have those partners' steps sort of documented alongside your own and sort of arrows indicating where certain touch points happen related to those things. Doing the two together is really valuable because, like I said, the service blueprint piece can kind of help to identify root causes of pain points that are identified in the current state. So you do them together, and ideally, when you put them on top of each other, you start to see some opportunities or some holes that you can try to fill in with new strategies and interventions. So this is kind of a really simplified example of a current state map. And it covers over 2 slides, so it keeps going. But essentially, it's documenting kind of how this person goes about identifying a place to go for their service. They visit that specialist. They have various labs performed. They have follow-up information. They get a prescription. They have a prescription order. They need to go get their medication. They have other follow-up things that they need to do. In this case, it's virtually. They may do some private research on their own where they do the thing of Googling their symptoms and finding out that they probably have cancer and all that kind of stuff. So these are all the different things that we have to keep in mind that our patients are doing in the background, not only from a sort of trying to keep the ask reasonable for patients, but trying to find more efficiencies. So if you know that they're going to be attending, some sort of community event where a lot of other patients with that disease will be, is there an opportunity to send a nurse from your team there to help answer some of those questions that maybe they weren't able to get to in their specialist visit? Just things like that. You're just looking for opportunities to leverage and improve that process. This is an actual example of a blueprint, a service blueprint that we worked with some providers to make in 2023 as part of our cardiac rehab team, the Michigan Cardiac Rehab Network. So this is a documentation of how a patient who has been discharged from some sort of cardiac procedure, like a TAV or SAVR or PCI, something like that, the steps that the staff are taking between referral and enrollment, some of the barriers that patients might experience throughout that workflow, and some of the ideas that they had around interventions that they could try to address some of those things. Okay. So now I'm going to dig a little bit more into the considerations piece. So let's say you've decided as a team, you'd like to give this a try or give another, in addition to calling it sort of patient journey mapping, a lot of people have referred to it as sort of human-centered design. There's a lot of similarities between the two, so I just want to mention that since that one might be more common. But anytime you decide to do that, there's a few important things, in my opinion, to keep in mind. So those key barriers or pain points that impact a patient's care are often very consistent across patients and come from sort of fundamental things that are going on that we're just going to talk through as a group. And so one of those has to do with processing capacity. So my background, I have an MPH, but I also have a master's degree in environmental psychology. And the primary focus for that is essentially, how do humans interact with their environment? How do they process information? And for the longest time, the field has been sort of leveraging this idea that, our brain has the ability to process and understand between 5 or 9 bits of information at a time. We can kind of juggle multiple things up here and understand them if it stays within that range. More recently, that estimate has been reduced to 3 to 7 because of the excess of information that is constantly, that we are constantly exposed to on a daily basis. What this is essentially saying is that we have a limited amount of attention, and when we are spreading it too thin, it's harder for us to remember things later. So that kind of feeling that you have when you're really stressed or really tired, and it's harder to remember. You might have read an entire page of something, gotten to the bottom of it and realized, I have no idea what I just read. I don't remember any of it. That is that in action. When we are we call it cognitively depleted, but more or less when we're tired or when we have a lot of other things grabbing our attention, we have weaker short-term memory, and that impacts our ability to be civil to those around us. So oftentimes this comes up when we talk about the differences between being in like the Midwest versus being in New York City. So people in New York City tend to be on the 3 end, and they tend to be really short with people, and they tend to be more rude on the street. It's just a little bit of a difference in terms of like your ability to rehab your attention. But anyway, people have a harder time solving problems. They have a harder time focusing and thinking ahead. And so one of the reasons that that's really relevant, obviously, is that when we get information overload as a patient and you're trying to give them all this information in an appointment with a specialist, maybe it's around their medications, maybe it's around what they can expect in the coming months following a diagnosis, you need to anticipate that they're going to forget most of it. I think the research says that of those who kind of remember a little bit, they actually only get half of that information that they say they remember correct. It's not kind of the end of the world. There's some ways around it, but I think people just need to be cognizant of the fact that just because you want to tell people as many things as you can on your checklist doesn't mean it's a good idea to do so. Two things that exacerbate that. One is minority stress. So that is a situation in which folks who are dealing with chronic stress related to their social position tend to have worse cognitive performance related to their processing capacity. So they're basically always at a 3 because they are constantly also keeping their mind on these other things that are a daily stress and a daily challenge in their life. It's similar for things related to social drivers of health. So those factors, they are always having to think about those things in the background, and that takes away some of their capacity to focus on their appointment or focus on what you're saying to them. And what this basically means overall is that one size isn't going to fit all. So you are going to have patients that you can kind of trust are going to do fine in their follow-up. They're going to retain the information. They seemed, you know, in the appointment, like it kind of landed. If you know that there's patients that are coming back a lot or that have kind of a history in their chart of kind of not being on their medications or having trouble with that, that might be an indication that they're experiencing some of these things. And you might need to rethink how you share that information. One of the ways that you can rethink sharing information is through storytelling. So a really effective way to get someone to remember details is to not give them a fact sheet about it, but integrate those details within a story. I don't know how many people on this call remember from their elementary school days the I'm Just a Bill video and song and story, but there's a reason they made that into a cartoon story. It's a very complex process to get legislation passed in this country, and this kind of song and story simplified it in a way that even an elementary school student could recall for you and explain the basic steps involved in passing a bill. That same strategy can work here in medicine as well. By communicating or framing that information in a certain way, you can kind of help people to remember information later on. So this will come up when we talk about strategies. So in the fall, when we did our breakouts, we did ask groups to do 2 things. So first, they drafted a service blueprint related to a CHF patient admitted for pulmonary edema. So we had them kind of write down what steps would you take at your site, what sort of touch points are there with other folks, what processes do you have in place, et cetera. And then they also documented from the patient's perspective using a specific persona that we provided to them, you know, what that patient's journey would be like. So we collated all that. And we were able to identify some common across the groups patient and provider pain points, and then also some possible opportunities for how we might improve care coordination and reduce some of those barriers. So the main challenges that came to the top, medication adherence and proper titration. So a lot of difficulties with having heart failure patients on the proper dosage of their medication, and also having as many as 50% of those patients not taking their medications at all or not properly. We know that medication non-adherence can increase mortality rate, emergency department visits, rehospitalizations, length of stay, all of that stuff. So we want them to be on their medication and be on it properly. We also heard a lot of folks mention that their patients were already feeling overwhelmed during their visits. So a lot of people responded pretty enthusiastically around this idea that, yeah, we recognize that it's information overload. They're very clearly overwhelmed. It's kind of that thing where you want to bring a family member when you're going to an appointment that might be scary or might be hard so that they can be your ears, because all you hear is what the doctor just said your diagnosis was. They all sort of had kind of examples of that experience with their patients. So that one was a common one. Obviously, frequent rehospitalizations, low follow-up rates in terms of outcomes that they're concerned about. And then another one that came up was lack of social support or lack of community among the patients. I think the fact that it's sort of more like a chronic illness, you want to have peers going through it that you can turn to when you have questions that aren't maybe a question that you would ask your doctor, that are more kind of, what can I do? Or what did you feel like, or how do you deal with X, whatever it is. So given that, we did come up with two ideas for what we think make a lot of sense for possible strategies for those challenges. One of them is going to be cardiac rehab, which is something that obviously we've been focused on for a long time, but this is a no-brainer of a connection for us in terms of the heart failure population. And then storytelling. So I'm going to go into the first one, which is going to be leading us into our first breakout activity as a group here. So those challenges I mentioned kind of appear along the left-hand side. And then the right-hand side column is sort of connecting it to a direct or related cardiac rehab benefit. So when I mentioned that people were saying, medication adherence, improper titration, we have heard from a heart failure physician who's the co-director of my CR. She's especially interested in titration difficulties around sort of her not having enough frequent like blood pressure readings or other vitals that help her to properly titrate medications for her patients. When patients are in cardiac rehab, they get those taken every single time they're in. So those are additional opportunities to get those types of numbers recorded in the system so the physician has more data to work with in order to make sure that their medications are at the proper dosage. It's also another engagement opportunity for you to provide information that maybe they missed in that appointment or that they have questions about, and they can use the cardiac rehab staff and nurses as another option for people to ask questions about. There's been sort of a hesitancy in the past from physicians to refer heart failure patients to cardiac rehab in terms of just being afraid that it's not safe. There's been a lot of research to contradict that in recent years, and those studies have been replicated multiple times. And I put a sort of link or a citation here for one of the founding articles that gets cited the most, but essentially it's very safe. It improves their quality of life. It improves their functionality. And it reduces those outcomes that we're all focused on: rehospitalization, mortality, things like that. And one of the core components of cardiac rehab that is really beneficial is that peer community piece. So there is a lot of class camaraderie that comes out of cardiac rehab. There is a mental health component. So cardiac rehab isn't just going to a gym and exercising. It has 6 other components to it outside of just exercise, having to do with stopping smoking, eating better. There's a mental health and therapy piece. And then there's generally also pieces for the family to help the family learn how they can be supportive. So there's a lot of wins there. So our first breakout group is going to be focused specifically on how do we get heart failure patients into cardiac rehab. what I'm going to be doing essentially is sharing a link, or if someone else can share it, because I can't see the chat right now. We're going to share a link to a Google slide presentation where you will see this patient journey map that you see here as a picture. It's developed as a slide. As a breakout group, you're going to modify this journey to be a better reflection of what that would look like for a heart failure patient at your institution. So this specific one was developed again in 2023 as really more focused on the procedure based cardiac rehab patients. So let's say someone went in for a PCI or a TAVR or a CABG even. This would be the workflow and the patient journey for that person, where they would have sort of an automatic referral generated as part of their procedure, and then it would sort of go from there. It's not that way for heart failure because you're not actually eligible to attend cardiac rehab until you basically get sick enough, is essentially it. So you have to be of a certain class and symptom level in order for your insurance to cover it. And so enrollment is going to look different because of those concerns that a lot of providers have around safety. Getting kind of clearance from a heart failure physician might be trickier or might look different and might not be at the end of this process as it is in this one. So your group is going to be making tweaks to these different steps. The blue squares are essentially a step that the provider takes or that the patient takes. The red circles are barriers, and the yellow clouds are opportunities for interventions or where additional support might be needed. So I put some bullet points for things to consider specific to heart failure that we're hoping to be cognizant of. And hopefully we can use this to generate some ideas around how we can get more people going. Because right now only 4% of heart failure patients are going to cardiac rehab. So we want that to be much higher. Are there any questions before we send people into their groups? We're going to have 10 minutes together to work on your slide with your facilitator, and then we'll come back.
Jane, this is Matt Orsay at Corewell. Just as a heads up, the link that you guys put in there is for a Google document. I know most organizations block Google, so like we can't open it up. For example, I know Henry Ford has the same thing. So
Okay.
just wanted to call that out that we won't be able to open that document.
Thank you for mentioning that. Each of you will have an MVC staff person in your breakout. So folks, I might suggest that what you do is share your screen in your breakout and have them tell you what to write if that's the case. Other folks, if you're able to access it, feel free to directly edit as you like. Okay. All right. Well, I'll see you all in 10 minutes then. All right, we're going to move right on to the next one. So that other sort of strategy that I teased earlier around storytelling, I think there are some opportunities to integrate storytelling throughout a patient's experience that will help with some of the challenges that we talked about. So the medication adherence one, just to start with, I know that at least in the literature, there's generally a fair amount of patients who experience just general confusion around their regimen, around what side effects to expect that are worrisome, what they should do about them. I think that it's not new to have patient stories as a really valuable sort of resource or document that you can share with people so they kind of can hear from others who are similar to them. But I think this idea of telling patient stories to help impart some of those details about medication regimen is kind of an untapped area and would make it easier for them to kind of prepare themselves. Similarly, if there's certain things about the progression of their illness, let's say the first time you're diagnosed with heart failure and you just have so many questions. What is my life going to look like? What can I do? What can I not do? I think that having, different stories that demonstrate the progression of things or what that you want to be modeled for that patient would be really valuable in terms of setting expectations and helping them to understand what their experience will be. And then similarly, we've talked about this already, but going back to there's information overload in a lot of these appointments. There's a lot of information we're trying to give patients in our 15, 20-minute time, and we just don't have the time we need to do it well. So I think having sort of a takeaway resource that reiterates or adds additional detail to certain things would be valuable because it will help those providers to not feel like they have to go through all those details in the appointment. Or maybe there can be, before they discharge, a resource that a nurse or some other navigator gives to them before discharge, talks through it a different day than during that time that they're with their doctor. So with that in mind, our second breakout is just going to be a brainstorm. So it's going to be 10 minutes again. You'll meet with your group. I believe it'll be randomized. You might not end up in the same group that you had prior, which is completely fine. But I'd like you to just discuss how you think storytelling might fit into your service model. Who do you think it should come from? What delivery method would that look like? You know, would it be something like a community group that already exists and you would send a nurse to attend once a month or something just to answer patient questions? Would it be some sort of physical digital PDF or booklet, or like a just a bill video, you know, that tells a story? So let's kick off into our breakout room, see what we can come up with, and then we'll come back together and close out our session for the day. First and foremost, thank you all for your participation today. I certainly had lots of great discussion and suggestions from you all. We will definitely be taking back all of our notes and suggestions from today, digest them as a team, come up with some plans for some resources we can hopefully get to you later this year to support our heart failure community. If there are information that you gleaned from today that are useful or you think, oh, that would be really helpful in this scenario, I really do encourage you to try to bring any of the principles from today to your meetings. Even if it's not journey mapping as an activity, but some of the concepts we talked about in terms of, you know, patient burnout, minority stress, that is going to be kind of at an all-time high right now. I don't know about you, but a lot of people on my and my family are kind of stressed right now. So please keep all these concepts and principles in mind to inform your work going forward. We did generate a template patient journey map that we shared after the fall breakout session, which I can include as an attachment again when we send our follow-up email. It kind of looked like this, but it was a PowerPoint document, you know, if you're looking for a template to do an activity. But like I said, if you have other comments or ideas from today, didn't have time to get to it in your group, please share them with us either via email or you can add them to those documents and send them back to us. We'd love to hear from you. And I will turn it over to Emily to close us out.
Great. Thank you, Jana. I'm just going to quickly share my screen with our last few little details here. Just did want to remind everyone of other upcoming work groups for Q2. So we've got 2 work groups a month of varying topics. We're going to have a lot of health in action work group opportunities over the next few. So we hope to see you there. And then, oh, my cursor just went away. Lastly, did just want to remind everyone that MVC's Spring Collaborative Wide Meeting is coming up on May 9th. It's going to be hosted at the H Hotel in Midland, Michigan. Registration is going to be opening up in mid-March, so be on the lookout for that. We hope to see you there. And we are also still accepting proposals for presentations for roundtables at our Spring Collaborative Wide meeting, as well as for future work groups and other presentation opportunities. So if you have a topic that you would love to share across MVC's membership, we would love to hear from you. You will receive a link to that presentation form in the follow-up email, as well as it'll be linked in the slides. It's on our website. And I think we can go ahead and share the link to complete the post-work group survey now. Just a reminder that if you're looking to receive P4P credit for your attendance today, to please complete that survey for the hospital that you would like your attendance credit to go to. All right, and with that, we will close out the work group. Thank you so much for joining us.